So good morning, everyone. Thanks for making time during what is a busy week. We're going to start by spending a little time talking about how to get started, how to build a narrative. And in the process, I will tell you my own story and my own path, which also was quite meandering. So we'll get to that in a minute. But the highlights here are start early, if you can. I couldn't. Sounds like Jen couldn't. But you can. You're here already. Find what you're passionate about. Define what success looks like to you, not to somebody else. To you. What's important to you? That'll be a theme I come back to a lot. Develop a mentorship team. Not just one mentor, but a team, and I'll talk a little bit about that, and there'll be a whole other session on mentorship a little later today. Write your goals down and look at them again and again and again and revise them. But write them down, because you won't remember exactly what you thought your goals were 3 years ago if you don't write them down and look at them. And then stay focused. This is really hard, and I'll talk about that a fair bit as it relates to my own failure to stay focused for quite a while. So is anyone in here a medical student? Great. Welcome. So this part is for you. And all of you mentor medical students. So this part is for you as well. Start early and broaden your perspective as early as you can. So when you talk to your medical student mentees, talk to them about what an academic career looks like versus a clinical career. Encourage them to look at what that feels like in different specialties. Most medical students will go from rotation to rotation thinking they've found their passion, but then they're passionate again and again and again. So you have to help them find what their goals are. And also, as you get to know your medical student mentees, learn what their strengths are, because there are some strengths that make emergency medicine easy, like feeling great about making decisions under conditions of uncertainty, right? That's our strength, right? We're poker players. But if that makes your medical student mentee shrivel on the vine, you have to help that person find a different field, right? And then as a resident, do we have any residents in here? No. All right. So as a resident, you want to reassess your priorities and think about what an academic career looks like. And what I'll say today, and you'll hear over and over again, is that academic jobs are different at different places. And you don't have to get discouraged by not fitting into the academic job definition at one place or another. So this comes back to what's important to you. And I tell my fourth-year residents as they're getting ready to graduate every year, or really as they're getting ready to become fourth-year residents, because that's the important time to have that discussion. What is important to you? You spent your whole career satisfying other people, right? Your parents push you to do really well in high school so you can go to a good college, and then some professor in college recognizes that you're really talented and pushes you forward, and then you've been in a good medical school, and lots of people are telling you how good you are, and if you just work hard, you can go to a great residency. And then your residency may have some stated goals or their mission. But at the end of all that, it's really up to you. And so what are your goals? What's important to you? What are you passionate about? What will make you happy? Because when you leave residency, of course, the focus of the faculty moves on to that next group. How many of you talk to your program director from where you trained or your APD more than once a month? So 3 people maybe. And how many more than every 6 months? Same 4 or 5 people. Okay, so the point is they're moving backwards, right? They're supposed to. They're supposed to focus on the new residents that come through, and you're supposed to go off and develop your career. So set your own goals, and then get the training you need to achieve them. Does this require fellowship? Well, that's an important question that you have to think about, and it depends a little bit on what your goals are. If you want to be a funded researcher, in my opinion, you need to do a postdoc, right? Someone who comes out of a PhD program does a postdoc. They don't automatically start up in their own lab. And physicians who come out of residency who want a funded career need protected time to develop research skills, unless it's part of what you already did before residency. You already got a PhD before you came to residency, you're probably ready for a faculty job. But if you haven't and you want a funded research career, you need some mentor training. And there are some discussions of this, I think, later in the day. On the other hand, I think the jury's still out on whether education fellowships are required for someone to have a career as an academic clinician educator. These fellowships are proliferating everywhere. How many of you have med ed fellowships at your own institutions already? so about half the room. And so that then leads to pressure for graduating residents who think they want a career as a clinician educator to do such a fellowship. But again, it comes down to what your goals are. So if you want a career doing medical education research, then that will require some mentored training. If you want to be a program director and you want to be a clinical expert and you want to teach residents and you want to write information in a way that other people, or share information, I should say, in a way that other people can easily assimilate it into their knowledge base, whether that's through traditional writing or through other ways of sharing information online, through social media, it's not clear to me that you need a fellowship for that. Define what will make you happy professionally, and then find the job that will allow you to do that. Don't do it the other way around. A lot of our residents really want to stay in our system. So their first question for me is, what are you looking for this year? And what I'm looking for this year should not be part of their equation, right? As you take your job and your next job, you want to define what will make you happy and then find the job that will allow you to grow in that way, rather than the other way around. If I hire someone for, let's say, a quality and safety position, and that person has no real interest in quality and safety, but really wants to be in my department, that's a recipe for failure. And at the end of that, we'll both be unhappy, right? The person who took that job and I will be unhappy. We'll both be unhappy with the performance. And then that person has to get another job, and who has to recommend him or her? Me. So don't do that. Figure out what makes you happy and then find the job where those opportunities are important. And I guess the corollary of that is take a job where what's important to you is important to the department chair. Because there's a broad vista of emergency medicine, right? Think of all the various subspecialties. Think of all the various ways a department could commit its resources, whether it's in EMS or toxicology or clinical research or basic research, medical education, wilderness medicine, medical simulation, pediatric emergency medicine. I could keep going, right? There's many, many, many. But if what you want to do isn't important to the department chair, no matter how well you do it, it's going to be hard to generate a lot of support. So I'll just give a very small personal example. In my department, we have not invested heavily in EMS. We have an EMS director. She interacts with our various ambulance companies, but we don't have more faculty than that who are EMS trained. We don't have an EMS fellowship. We don't do a lot of research in that area. And so taking a job with a focus on pre-hospital care in my department is not a recipe for success. It's not where we are investing our resources. So if I have a resident or a young faculty member who's interested in that, I encourage them to think about other locations where they can be supported by the chair more fully than I'm going to support that particular aspect of our very broad specialty. Mentorship and sponsorship. So there's going to be a whole section on mentorship and mentorship later, but I'll just tell this in the context of my own story. I think everybody knows that mentorship and sponsorship are not the same thing, right? Sponsors are people who talk about you, they find you opportunities, but they don't listen to you that much, and they're not going to be engaged day to day or week to week in your activities. Your department chair must be a sponsor, but she or he does not have to be one of your mentors. Your division chief really has to be both, but most certainly should be a mentor, right? If you find yourself in a division of wilderness medicine, your division chief has to be one of your mentors. So we're supposed to talk about our own story. My story is convoluted. You will not follow it. I went to medical school in New York City at Columbia at that time, and actually until recently there was no Department of Emergency Medicine there. And when I graduated from medical school in 1989, I had no idea that emergency medicine was a specialty. So I managed to get through 4 years at a pretty well thought of medical school without understanding that emergency medicine was a specialty in which one could train. So that's impossible now, but could happen along the way, and it led to a lot of professional drift for me. So I ended up as a medical resident, only then realized I was in the wrong specialty, drifted for a while, and only much later did I understand the importance of mentorship. So how many of you already have a mentorship team that is defined? I assume this is mostly junior faculty, right? We established that there's one student and no resident, so everyone else is junior faculty. How many here have a mentorship team that's defined? Like you know who they are and they know who they are. So about a third of the room. So for the other group, how many of you think you have mentors, but if I asked them who their mentees were, they wouldn't name you? Right? So that's a problem, right? So you have to have a mentorship team. And it can't just be one person, right? And it's important that those people are defined as such. So when I hire a new faculty member, actually, I hired one of Bill's fellows a few years ago. She was awesome. And sorry to call you out, but you're here. And we created a mentorship team for her that was defined. Every member of her mentorship team understands that they are her mentor. They are part of her team, and we will meet with her regularly. And that mentorship team has been a critical part of her success. And don't be afraid to look outside your own department, depending on what you want to do. Right? If you're a health services researcher, like the person I recruited from Michigan, a member of her mentorship team is in the Department of Medicine. So 2 in the Department of Emergency Medicine, 1 in the Department of Neurology, and 1 in the Department of Medicine. So look outside your own department. And this is just a plug for engaging in mentoring yourself. I'm sure you already do it, but it's a great way to generate interest in younger people who want to do the things that you already think are important. So engage at the medical school, engage with your residents, and who knows, you'll find the next you to come join you and expand your own impact. So again, just a word about mentors, and you need all of these. So the reverse mentor is the mentees, and I put that over here, right? Because you learn a lot from your mentees. I'm sure you've already experienced that. But you want a mentorship team that has some peer mentors. Those are the people that you trained with or who are also junior faculty doing similar work that you can bounce ideas off of in a low-risk, low-threat, low-fear environment. And you need 1 or 2 of those, and I'm sure you have those. Then you need some content mentors, and for those of you doing research, you need, I call those research mentors. These are really the experts in the area that you're most interested in who will help guide your content growth, whether that's research or education or policy or something else. You need at least 1 of those people, and it could be your division chief. It probably isn't going to be your department chair. Then you need career mentors, and this could also be a division chief. This could also be your program director from where you came from. It could also be your department chair from where you came from or where you are now. And then you need life mentors who are often outside of medicine altogether. I think my most important life mentor is actually my wife, who grounds me and helps me see outside of the work part of my circle, which sometimes overwhelms the other things. So you need all of these. And as I mentioned, your sponsors may be career mentors or life mentors, or they may be independent. And you never get too old for mentorship. I still have a mentorship team. One's in emergency medicine, a man by the name of Peter Rosen, who I talk to every month, and one who was never in emergency medicine, a surgeon at Mass General by the name of Jerry Austin. They're both in their late 80s. I meet with both of them, one by phone and one in person every month. And they're both in their late 80s, which makes me nervous about finding my next group of mentors, but I will continue to require mentorship my whole career, just as you will, just as you will. Let's skip this in the interest of time. So in our department, when we hire you, you are assigned to a division or program, and you are assigned to a mentorship team. This slide's just a little old, and I just pulled it because it just describes our most recent programs. But if we hired you into one of these programs, you would be assigned to that team, and you would be assigned to a mentorship team. It would be written down, and the people who we assigned as your mentors would understand that they were your mentors. And if I asked them, who are your mentees on the faculty, they would name you. I think that's very important. The mentor has to know that he or she is important to you, just like you have to know who your mentors are. All right, so on to the groundwork for success. So how many of you have an annual meeting with your department chair? Wow, so it's not everyone. So that's okay. It was more than half, but it should be everybody. Everyone in this room is interested in an academic career. You wouldn't be here otherwise. So everyone should have an annual meeting with your department chair. That's important. And it should be specific around career guidance. It should not be about that difficult case you had last month or that tough interaction you had with someone outside your department. Those meetings happen anyway. But you should have a scheduled annual meeting with your chair to talk about your goals. And then I really encourage you, how many of you write down your goals each year, like as part of your annual meeting with your chair or some other reason? So about a third of you. So that's great. I recommend that you write a 5-year plan down and that you also write an annual plan down. And at the end of each year, You review it critically yourself, and then review it critically with your department chair. And every person in my department does that, and I do it with the CEO of my hospital. And I have to self-assess on my goals from last year. I have to give I use color. Green for we did it, yellow, we sort of did it, red, we didn't do it at all. And then I have to admit to a whole bunch of things I wasn't smart enough to put on my list that hadn't emerged yet and became important goals. That happens, right? So you have to revise your goals, you have to look at them critically, you have to be honest with yourself. What's working, what isn't, why isn't it working? And as part of that 5-year plan, what is your timeline for promotion? How many of you have a date in mind right now as you sit here for your next promotion? 2, 3, 4, a few people, but not enough. Every person should have a time, even if it's 5 years from now, because actually it takes sometimes 5 years to plan and accomplish all the things that will be necessary for you to get promoted. So when you leave here, you should write down, my 5-year goal is to get promoted in year 3 and to do X, Y, Z in year 4 and something like that. And then look at it again next year and see if you're really on track for that and revise it. Pearls for success. So the most important thing, and I said at the beginning, is to find what you're passionate about. Don't figure out what someone else is passionate about and try to do that. That will not work. I did that in the beginning. That fails. All right, I've got a stack of abstracts that never got written into papers and never will. They got presented at a bunch of throwaway meetings. The goal cannot be to present an abstract at a meeting. That can't be your goal. If that's your goal, your impact is going to be really, really small. And we're here to have impact, right? We'll get to that in a second. So find your own passion. Don't let someone else tell you what it might be. You know what it is. Find like-minded collaborators. Don't be afraid to look outside your department, outside your institution, across your university, or across medical schools. You're sitting in a room with like-minded people who want to get promoted, who want to build academic careers. I'll bet a lot of you have overlapping interests. Find out what they are. Who knows? You might find a research partner or a writing partner. Stay focused. I've said this 3 times. It probably won't be the last time. If you look at my CV, the first 5 years, I probably wrote on 10 different topics. That's no way to advance your career. It's no way to have impact, and it's no way to get promoted. You have to show impact. So if you write on 10 different topics, it's hard to prove you really have impact in any of them. So whatever it is that you're most interested in, that's your focus. That's what you speak about. That's what you write about. That's what you tweet about. Don't accept an offer to write a chapter on altered mental status in the Rosen textbook when you're really interested in cardiovascular emergencies, like I did. It was a lot of work, and it didn't help me at all. And I did that over and over and over again in the beginning. So you have to be intentional about staying focused. You have to seek opportunities to establish your brand. Part of that is speaking. All right, you have to speak locally. You first have to become a local expert. Let's say you're interested in sepsis. All right, so you're helping build your sepsis guidelines, and you're helping an interdisciplinary group improve sepsis bundle care in your hospital, and then you're speaking about it to your residents, and you're speaking about it at local meetings, and eventually you're speaking about it at national meetings. Over and over again, intentionally building your brand. And then your sponsors really have to help you with this. If your sponsor, if your department chair is not finding opportunities for you to write and speak, she or he is not doing their job, and you need to ask them to help you. That's part of that annual meeting. If a year went by and you did not get good sponsorship, just have to ask for it. Ask for it again and again. And then this is not something I'm good at, but I've watched the power of social media, frankly, in a terrifying way. It elected our last president, I think, in part. But more importantly for this group, it really has been harnessed in useful ways by colleagues across our specialty to establish their brand. And that doesn't mean you have to, tweet constantly and have thousands of followers, but people are talking to each other in our specialty on social media now. And I'm a lurker. My wife calls me a lurker because I read everything, but I don't know how to actually make a tweet, or a twit, as she calls me. But I think it's important in this generation to establish your brand, and this is one important way. So this is not something I'm expert at. Someone else can help you with that if you're not already doing it. I promised I would talk about this. So when Rich Wolfe asked me to do this, there were 2 things he didn't tell me. The first was he didn't tell me this was on Tuesday, which is fine. I wanted to be in Vegas for a whole week. And the second thing he told me is, I really want you to just talk about your thoughts about protected time, because this is a kind of a hot topic for everyone who's recently come out of residency and negotiated an academic job, and it's a hot topic at the chairs meetings as well, where we talk about what this means. And so everyone's asking for it. Chairs don't like it, right, because they have budgets to answer to. And I would just remind all of you that academic jobs have protected time built in already. If you don't believe me, just go ask the local community hospital what a full-time equivalent is, and you know it's several hundred more hours than the full-time equivalent at your academic medical center. So you already have those several hundred hours of protected time built into your job. And so on top of that, the true measure of protected time is all about the denominator, right? So one idea that was kicked around at the chairs meeting is we should all raise our FTE to 1,400 hours and give everyone 10% protected time. No problem recruiting anymore. And guess what? You'd all be working more hours, right? Because 10% of 1,400 doesn't get you back to 1,200, which is where most jobs start. So, you know, so the denominator is always time and money, right? And I think the main thing here is just to make yourself indispensable, show value, and then grants and money and time will follow. And if you don't show value, it really doesn't matter what you were promised up front, because you will not be supported longitudinally. Grants, papers, and perseverance. For those of you interested in research-based careers, you got to apply for a lot of grants. You got to accept rejection. You probably haven't been rejected much to this point, right? You were a great high school student, you went to a great college, you got into medical school, which almost nobody does. You thrived in medical school and got into a really competitive residency, and now you all have junior faculty jobs. So you haven't been rejected very much. Get used to it. If you apply for grants, you will get rejected over and over again. That's okay. That's normal, in fact. Keep applying. Keep applying, get better mentorship, work with well-funded investigators, because that's the key to early support on grants. And then focus on impact, right? So the growth of these throwaway, online, self-publishing journals has led to tons and tons of papers being published that have no impact and almost no importance, and no one reads. And I understand that people like me also say, well, why haven't you published anything? How are we going to get you promoted if you haven't written anything? But what we're really about when it comes to doing research is trying to change patient care for the better. We want to have impact on patient care. So focus on quality, most importantly, which is not to say that quantity doesn't matter. The other thing is that author position matters. And depending on which medical school you're getting promoted in, it matters a lot. So in my medical school, if you're not first author or last author, you almost get no credit for being on that paper. And if you're not first author in the beginning, it's hard to get promoted to assistant professor, and then you need to transition to senior author, or you won't get promoted to associate professor. Now, that's not going to be the case at every medical school, and you need to learn the rules of the game for promotion, and we'll hear about that later today. But you've got to settle this in advance. You can't say, oh, I'd like to be senior author on that paper with your collaborators as the paper's being written, right? It's when you put in that RRB proposal, sit around and talk about the idea, that you have to settle authorship. And as I said, don't get rejected. Don't get discouraged, rather. You will get rejected. Your grants will get rejected, and your papers will get rejected. That's okay. Rejection from a top-tier journal with interesting comments will make you a better paper writer. It will make you a better methodology-based researcher, and it will help you write a better paper that will get accepted at the next place you try. The last slide, I think, is the pitfalls. You can't say yes to everything. This comes back to focus. But you really have to be open to opportunity when it knocks, because interesting opportunities will come when you don't expect it. They're never going to come at convenient times, right? How many of you feel like taking on a new project right now? I don't, right? You don't. But an interesting opportunity, when it comes, you have to make time for it. An opportunity to collaborate with someone who you think will be a great mentor, even if it's a little more work, you have to be open to that opportunity. Set aside time to write and think. How many of you set aside an academic day or an academic half day every single week? That is great. 3 people. For those people, that is great. For the rest of you, set aside some time and treat it like a shift. Treat it like a shift. You wouldn't schedule a meeting in the middle of a shift. You wouldn't decide to get a haircut in the middle of a shift. Right? You wouldn't take a phone call in the middle of a shift. Your academic day is for writing and thinking. If you don't set aside time for writing and thinking, that stuff has no deadline, right? That paper can be written next week or next month. It'll never get written. And you won't think about what your 1-, 3-, and 5-year plan is if you don't set aside time to think. So please do that, and kudos to the few of you who are already doing it. I've found that my current group of junior faculty are really interested in a title. Director of something, assistant director of something, associate director of something. It usually is part of that protected time discussion. But most importantly, think about whether you want to take on administrative responsibility at this point in your career. Because you only have a certain amount of time a week, right? I mean, how many hours are you willing to put into this job? And how many hours are there in a week? Administrative burden is not just using Epic to write a chart, right? Administrative burden is being the director of a program that has 6 meetings a month, which don't go on your CV, can't get you promoted, and don't really lead to improvements in your work-life balance. So think about whether it's really worth taking on a director of blank at an early point in your career. I generally dissuade my junior faculty from doing that and say that they should spend the time building up the foundation of what will be their career. The directorships will come later. If you are a strong academician in the early phase of your career, you will be a hotly recruited director of something later on. Don't lose focus. I promised I'd say it one more time. Don't lose focus. And then anyone can identify problems. All right? Every single person in my department can identify a problem. Very few people come to me with problems and solutions, and even fewer people come to me with problems and solutions that they themselves are going to implement. Those people are really valuable. Right? You could be one of those people. Identify a problem, come up with a solution, and figure out how you're going to implement it. Make yourself valuable. When you make yourself valuable, all the other good things you want will come. So, I was supposed to say that you could have interrupted me at any time and asked questions, but I didn't, so you didn't. But this is the time. Who has questions or comments? Yes?
I think this works. Okay. Yeah. Sure. Mike Chari, I'm a Tox Fellow at Children's. And so back on the protected time question, there's when PhDs are recruited for their first thing, and to continue that analogy, there's also discussion of something called the startup package, because, you know, no researcher is an island, and you can sit alone in a room and think great thoughts, but you need preliminary data, and a lot of times that is not, for many grants or something, that may not just be chart review. You need to pay for time at a core facility or something like that. So how does one ask for both?
Yeah. So this comes back, I think, to picking a job which is a priority for your department and a priority for your department chair. So not every faculty recruit will be able to make a sympathetic argument for protected time, but if, let's say hypothetically, a department chair is building a tox program and wants to hire a young, newly trained, motivated person who wants a research career, and again, I would just make that distinction. If you want a research career and you've demonstrated interest and aptitude in this, then you have an argument for protected time and startup package. If your interest in academics is more along the lines of clinician educator or clinician advocate, which overlaps a little bit and are very important and make a big parts of every faculty, every academic faculty, then your argument for protected time is not as strong. I can just tell you what we do. It's not the same everywhere, but if I hired someone out of a clinical scholars program, hypothetically, just to go back to the theme here, I offer protected time for 3 years. And after that, the person has to fill in the delta with grants. They can't fill in the delta with shifts. That's a very important distinction, right? Because what I don't want is someone who doesn't really want a research career. And after 3 years, they're happy being a clinician educator if they don't have success as a researcher. If I'm trying to hire a clinician researcher, I set it up so that I give a lot of support. In this case, 1/3 support for 3 years, plus a startup package. But if the person doesn't develop into a researcher, they don't get to now work 12 shifts a month and join my clinician educator faculty. They really have to go. Now, some people believe in themselves and will bet on that because it's a little bit of a gamble. And other people are not as committed or not as sure, and they don't like that offer. It's worked really well for me. But but I don't know that it's the only solution. But I do think that if someone is committed to a career in investigation, as you say, they can't start off with grant funding that will allow them to buy time out of a biostats core, let's say, for example, the example you were giving. The other thing that we will try to do is pair them. I mean, if you're hiring someone thoughtfully, you're pairing her or him with a mentor who's already funded. And you're building into a program that already has a lot of resources. And part of the commitment is that the resources, for my example, our emergency medicine network is very well funded. Has lots of statistical support, has opportunities for young researchers to harness databases. They don't have to go out and buy them or create them. They're right there. So access to that sort of thing is part of a package, even though it may not have a dollar associated with it. I hope I answered your question. Other questions?
I'll say one thing about the protected time, because I think that, unfortunately that was your hot topic. But I think something that comes up really early and often, right? It's essentially, what will my buy down be, right? That word has to go away, I think, because it's one pie. Money doesn't grow on trees, right? And time is money, essentially, in academics. So where does the money come from? So in the research pillar, it's traditionally grant funding, right? It can be maybe even donors or foundation money, but the money has to be, come from somewhere, because the chair doesn't go out and pick it. You have a money tree there, over there?
Not anymore.
Right. And sometimes, so then you think about the education pillar, where does their money come from? Does anyone know? So if you want to do anything in education, so GME has its own money, graduate medical education, right? And UME has its own money, right? Is this making sense? So honestly, the budget that I think is most difficult to fund is probably the clinical operations budget, because that's just sort of the working budget. I like to use ultrasound a lot as an example. Ultrasound can have either a very small, limited budget, or they can start billing and collecting money. Certain places in the country are doing a fabulous job of that. Or you can even offer a course. And then people within the institution can use their benefit, right, to pay for that FTE. So I think it's a really complicated discussion that will probably be ongoing throughout the day. But it's great to hear the chair's perspective, because essentially, you going to look for a job or stay in a job, essentially you want to know, how will I be protected, right? How will my passion, my area of interest, my impact, how will I be able to do that and work, right? That's essentially the question, and I think that that's a hard question to answer, but it helps to understand where the money comes from, right? Does that make sense? All right, so we'll probably take, let's see, where are we here? We have about 10 more minutes of questions around this. Yeah, good.
Hi, I'm Pavitra from University of Illinois at Chicago. That was a wonderful talk and a lot of great points. So going back to your kind of repeated point of trying not to lose focus, I guess I personally, I think I struggle with that. I'm an early career investigator, faculty, junior faculty. But, I feel like we are at the exploration phase, right? Like you still trying to define what that niche is and still trying to maybe expand your connections and all of that. So, most of my research is in cardiovascular emergencies, but now I've had a newfound interest in something else, like more on, narrative medicine and resident wellness, and I'm kind of caught in between trying to figure out, well, is that losing focus, or should I do a little bit of both? So I guess if you could just expound a little bit more on that.
Sure. I mean, that's a great question, because just as I had no idea during medical school about emergency medicine, or during residency, or really in the first part of my career what academic medicine was, I think all of us are allowed to change our mind or to find other things that are interesting. And I think that's normal, and it happens a lot. I think the goal should always be to try to explore as early as you can. So, tell your resident mentees to get involved in 5 things. Tell them to look outside of what an academic job looks like in your department, because we didn't really get into this, but academic jobs are not all the same, and departments are not all the same in what they're focusing on. So I think it's common for people to start with a focus in one area and then find that they're less interested in that, or, cardiovascular research is hard. You need a mentorship team, you need a commitment of the institution, and then you have to be part of a clinical trials network. So that's a lot. And I don't know whether those resources are available to you, but if they are, then there's a lot to dig into. And if they're not, then it's really hard to get traction. So I think that's sort of phase one of thinking about your own career. And then the second is, what makes you the happiest? Are you happy looking at data sets, or are you happy thinking about how to make our job better for all of us, and as a result, better for our patients, as would be, a focus on both resident and physician wellness, and maybe that streams into operations and how to reduce administrative burden. So it's really about you and what you're most interested in, and I think that you or any of us get to change our focus over time. It's just that the earlier you can find the thing you're most interested in, the easier it is to have a trajectory for success. And just again, speaking from the chair standpoint, I don't know how explicit your roles were when you were hired, but if I had hired you to be a cardiovascular researcher and invested in you in the package I talked about before, depending on whether that was your goal or not, I probably wouldn't be so happy if, I don't know how long you've been out, but let's just say a few years, within a couple of years, 1 year, is that what you said? 3 years. So within a couple of years, you're no longer doing what I thought I hired you for. And I think that's really important. You have to make sure that you and whoever hires you are really thinking about the same thing for you, because that will be how you are judged. Now, it's perfectly fine to change your mind. I think that's allowable. But it's also possible that what a chair needs is what she hired you for in the first place. And that's the priority. So that you run the risk a little bit, depending on where you are and what the priorities are, of your job really not being that flexible. And I think that just really depends on where you are and what the priorities are. There was a question over here. No? Yes?
My name's Nate. I'm from Riverside, which is on coastal Virginia, Newport News. And I'm a TY program director. We're starting an ER residency. I'm being pulled into the ER in addition. But going on to her question, one thing that can help balance, because I have many bosses at this point, one thing that helps balance my new interest is leveraging other people in other departments to work with me on the wellness stuff, so I can continue to work through that as my interest is, a little bit more away from but I can still on the other lane of what I was really hired to do. I can keep doing that myself, but I can leverage other people to help all the time that I can't support the wellness initiatives and things like that. So really going outside of the department is a leverage move that can probably balance it out a little bit better too.
Yeah, I think that's a great point. I think going outside the department is something we don't do enough. Finding mentors who are doing the types of things you're interested in, whether it's in gun violence prevention or wellness or research. I mean, you're in a big, vibrant medical center with lots of people who have lots of passions, and it can't all be just in your department. So I really encourage that. I think that's the right thing to do, and I think you should establish really important relationships early that can be fruitful on both sides. We do that. We try to do that a lot. Am I out of time?
I think so.
Looks like it.
That was great. The one thing I was thinking is, so when you find your one thing, skill set, so you have to be good at it, passion, and an unmet need that helps, right? Because if you're doing the same thing that everyone else is doing, you're not as valuable to the department. So keep those things in mind. That was great. Thank you so much.